Hello everybody, welcome from Western Australia. I understand we've got 300 online today to reflect on the first 6 months of operation of the VAD here in Western Australia. I know that we've got a lot of people from Western Australia, but we've also got people from interstate, so I'd like to welcome you in particular. I'd also like to just acknowledge that we here in the Department of Health are meeting on Wajak Noongar Puja, and I'd like to acknowledge the elders, past, present and emerging. I'd like to also acknowledge their traditional custodianship of the land at which we're meeting. And I'd like to extend that acknowledgement to the elders of the lands on which you are meeting today as well. Let me give you a quick introduction to how we got here. Really, voluntary-assisted dying in Western Australia began with a commitment from government to engage with the community and with public opinion on the subject. And the Joint Select Committee on End-of-Life Choices made the recommendation that a bill be presented to Parliament on voluntary-assisted dying. And that draft of the bill was fashioned by a ministerial expert panel, which was chaired by Malcolm McCusker. The bill was introduced into Parliament in August 2019. It was passed in early December and it received royal assent on the 19th of December 2019. And that really set the clock ticking for the implementation. We had 18 months in which to give effect to the provisions of the Act, and voluntary assisted dying became a choice for eligible Western Australians in July of last year. There was a lot of work to be done, and I'd like to just acknowledge a lot of the people here in the room with me who really ensured that we had an excellent process. There was people obviously from my division, the Clinical Excellence Division in the Department of Health, but we were working really hand in glove with our legal services team, and I think the outcome was absolutely excellent. In that 18 months during which we prepared the work for the implementation of the Act, there was a lot to be done. We had to obviously prepare guidelines. We had to prepare information for consumers and doctors who might be involved. We had to organise training. We had to set up the board, and Scott Blackwell, who will follow me, will talk about the function of the board shortly. We had to set up an information management system to capture the information from the practitioners as their patients went through the process of the voluntary assisted dying. We also had to establish a care navigator service that would cover the whole state, and you'll hear shortly from Alice Herring about that, and a statewide pharmacy service, and Brenda Shum will talk about that too. I'd particularly like to acknowledge the involvement of our health service providers in setting this up, particularly also the primary care for their contributions to the implementation of the Act. So as I say, it became a choice for eligible Western Australians on the 1st of July 2021. We've now been operating for just over 6 months. I think this is a great opportunity just to look back over that and see what's worked well, what could be improved. I think the general feeling is that it's worked extremely well, and that those who have participated in the process, either as a practitioner or as a family member or a patient themselves, have found it a very well organised and compassionate service. So really that's all I have to say. We're going to hear from the individuals who've been doing some of that work over the past 6 months. And there'll be an opportunity to have a discussion about what worked well and what could be improved. And we're really looking forward to having your input into any improvements that might be made. So that's all I have to say. I'd just like to hand over to Amanda Botter, who's absolutely been critical in a lot of this work, and ask her to introduce Scott Blackwell, the next speaker.
Thanks so much, James, and thank you for the welcome and acknowledgements this morning. It's much appreciated. And particularly for those not in WA who don't know James, he's our Assistant Director General of Clinical Excellence at the Department and Executive Sponsor for this work. And we're really grateful for his time this morning to welcome the forum. So our first forum session today will provide perspectives from voluntary assisted dying structures and services. And our first presentation will be from Dr. Scott Blackwell, Chair of the Voluntary Assisted Dying Board, to provide an update from the Voluntary Assisted Dying Board on the first 6 months of voluntary assisted dying. Thank you, Scott.
We won't be the speaker in the hot seat. Thank you. Thanks very much, James. And good morning to you all. It's really interesting sitting here looking at 300 people I can't see, but somehow it's good because you feel somewhat less nervous than you do if you look across a room with 300 odd people. So good morning and welcome. And as James has said, many of you are here in Western Australia, but we also have quite a few people in other parts of the country, and we welcome you as well. And I'd particularly like to say hello to my friend Roger Hunt in South Australia, who was on our ministerial expert panel and has now got an implementation role in South Australia. And we're always willing to help all other jurisdictions who are following us along the pathway that we've trodden. You'll all be very interested in the data, of course, and we will talk a little bit about the data. But more importantly, we will reflect mostly on the people. The emphasis during the implementation was always about the people. And so that's continued through our work as the board has developed its processes. James did reflect a little bit on how we got here, and I'll look at it perhaps from a little bit different sort of point of view, and continuing the theme that I wish to create here. And really this legislation came from the will of the people, and that had been there for quite some time. And in fact, our new Minister for Health here, Sanderson, led the Joint Select Committee on End of Life Choices. So we're happy to have her as a new minister because it might be good for us. But they actually engaged in a broad consultation in producing the outcome that they produced, which then led to Malcolm McCuster's ministerial expert panel, and again, a very extensive, probably the most extensive community consultation that's ever happened in Western Australia on a health matter occurred during that time. And so the input of the people was continuous through this. And when I look at the Act that eventually came our way at the end of 2019, it really is the people's legislation. And I think that is how we've looked at it from implementation on. During the implementation time, we always looked at our work basically in the sense of a West Australian person who had an illness that was going to lead to their death reasonably soon, and a person who was suffering in a manner unacceptable to themselves. So we functioned around that sort of concept so that we got to all the implementation outcomes that we needed. And we had 8 work streams working on the vast array of things that you need to address. And that work was very good. But I think keeping that focus on that person emerged very early on, and then developed into a focus on the people who would enable this to happen. So the theme actually really remained about the people. From that commencement in the 1st of July 2021 to now, the board was formed on that day, and we can talk a little bit about what's happened in the first 6 months. The people who are the board, apart from myself, are Colin Holt, who's a former member of the upper house in the West Australian Parliament and is the deputy. Rob Edis, who's a neurologist and have been a very strong advocate for motor neurone disease over many years. And Rob is my right hand, hard-headed hard-hitting man that I love to have on the board, but he does keep me honest. Maria Osman was on the ministerial expert panel, who brings to us a lot of multicultural input, and she also has a very strong human rights background as well. Linda Savage is a lawyer. Linda also has been a member of Parliament in Western Australia in the Upper House, and so she keeps us very straight and honest on the legal side. So the board is small, and I think if I can reflect on that for those who are looking ahead, I think a small board works better than a big board. There's probably a number that beyond which you go that gets too wieldy, but 5 is working extremely well from our point of view. The functions of the board are there on your screen, and these are the functions that are outlined by the legislation, so we don't have any choice in that. This is what we do. We monitor the operations of the Act. We refer matters to relevant persons or agencies, and that means matters that are aberrations from what should happen. We've had no referrals at this stage. We provide advice, information and reports to the Minister and the CEO. We have a statutory obligation to provide an annual report, but we do provide updates over time. And we've taken the responsible position of knowing that although we actually are collecting a whole lot of data about voluntary assisted dying, that it's ours to be the custodian of, but it's really the Minister and the CEO whose role it is to say what happens to this data and where it goes. We are just getting to the point of analysis and research, and so we do collect and use the information within the limits of what the board has actually given us. So let's have a look at how this happens sort of on a day-to-day basis. If we can just, this is actually a simple overview that comes from our implementation time, which actually just runs you through the day-to-day process from the first request to the first assessment, the consulting assessment, the final review. Each of those steps has documentation and has reporting requirements that come through to the board. And this is overseen by the Secretariat of the board. So if you're looking at developing a board, those in other jurisdictions, look to how you bring through the knowledge that's going through the process of implementation. Underpinning this is the voluntary assisted dying implementation management system. And again, we thank James for the fact that when we twisted his arm during implementation to spend on this, to do it well, that it has actually paid us back in spades. Yes, there are some bits about it that actually need to be looked at and upgraded and that from time to time, but actually getting the technology right is actually really important to the outcome of this whole process. So let's look at what we focused on as a board in the first 6 months. And yes, I will get to the data. It's, people think that we're a board and we're going to talk numbers, but those of you who've known me, worked with me for a long time will know I'm not a numbers man. And I think from our point of view, the important things that we do, apart from monitoring the process from day to day and to collect all the data that we need to collect, is to look at voluntary assisted dying not as a new standalone service in end-of-life care, but as a new choice that fits within the already established realm of end-of-life care. And I think it's really important to see it that way. And therefore, there are a lot of other people who are really important to how the outcome is for the person who actually makes a first request. So we've developed a very person-centred approach, even at a board level, to develop and support this high quality of care that is needed in voluntary assisted dying. And if you look at the requirements of the board in terms of monitoring and making sure the right things happen, if we actually look at it at this level, then we are doing preparatory work and preventative work from things potentially going wrong down the track. If we get the people right, then you will get better outcomes down the track. And that, I think, has been very important to the way that we have worked. In the first 6 months, we've learned that developing relationships has been really central to what we've done. And the most important relationships for us are relationships with the practitioners, the care navigators, the pharmacists, and other people involved, although we don't connect with them as much as those three do. It has been amazing to us to actually see the quality of commitment and care, the sensitivity of the work that the practitioners, the care navigators and the pharmacists do, I think is something that you cannot underestimate. And I'm happy to say that in the first 6 months, that has been for me the outstanding achievement of the whole process. So let's talk about some numbers. So, because I've talked about the people now. The numbers, as I've said before, we are we collect the data, but it's up to the minister as to when that data is released, really. And this is the 4-month data that was available when presented in Parliament back in November. We have got 6-month figures which are with the minister at the moment, and they'll become public soon. But I think it's fair to say, looking at those figures, you'll get a very good idea of the pace at which voluntary assisted dying has taken off in Western Australia. And if we extrapolate from those figures to where we are now, the rate is remaining the same. And there seems to be a fairly clear picture now that this is the rate at which voluntary assisted dying will be requested and will be carried through. If we look back to where we started, we thought, based on the Victorian experience and their first 12 months, that we would look to something like 50 to 70 Western Australians getting to dying via the voluntary assisted dying process in the first year. We have 50 people who've died in the first 4 months from voluntary assisted dying process. So we were running at roughly around about 3 times the expected volume that we thought that would happen. So I think what we've clearly done here in Western Australia through that process of broad consultation, through the implementation, and before that, the development of the legislation, I think we have developed legislation that is good legislation, and I think its implementation has meant that the public have, in actual fact, established what we set out to establish, and that was safety and access. And I think they are the two really key things that we've focused on and achieved in that time. I think we've confirmed that voluntary assisted dying is a strong choice in Western Australians, and I think we've probably fulfilled the will of the people. So moving forward, I think as a board, we are responsible for compliance at all levels, and that we will follow through. And I think I've outlined fairly clear that we have a people approach to that, as well as a numbers approach to that. Education and continuous improvement is the basis of how we work. And as far as the practitioners, the care navigators and so on are concerned, actually looking at issues that crop up, taking them as a point of education is really where we're likely to go. So the volume of the work that we have means that we work hard, and that's good. And so far, so good. Thank you.
Thank you so much, Scott, for your presentation. And can I acknowledge as well Scott's role as a member of the Ministerial Expert Panel, Chair of the Implementation Leadership Team. We've been incredibly lucky to be ongoing beneficiaries of your expertise and leadership, so thank you very much.
I promise I'll retire sometime.
I know people will have questions for Scott, and we will come to questions in the panel session at the end of this item. I'd now like to introduce Ms. Alice Herring, who's the Clinical Nurse Consultant for the WA Voluntary Assisted Dying Statewide Care Navigator Service, and magically she appears from behind the screen. Alice will provide an update from the Care Navigator Service in terms of the first 6 months of voluntary assisted dying. Thanks, Alice.
Wonderful. Thanks, Savannah, and thank you, Scott, for your wonderful insight into the start of our journey. So I am very privileged to be the clinical nurse consultant supporting the WA Voluntary Assisted Dying Statewide Care Navigator Service. Still hasn't got any easier for us to answer the phones. It's a very long name. So for those of you who are working on this in your state, pick something that makes a really nice acronym. So just flip over to the next slide, please, guys. So for anyone who hasn't heard of our service before, we were established to support anyone in the VAD space. So everything from a person with questions in relation to VAD through to health professionals who may be a GP who's had a patient ask them to support their access to VAD, to our practitioners who are formally trained in this space, the service providers who provide care for patients working through this, and members of the community and people and their families. So we do provide both general and specific information and support to people in this space, and do have a key role to play in linking patients with practitioners who have formally completed the training and are in a position to accept their first request, in addition to making sure that people do have access wherever possible to the whole scope of supports and care in relation to their end of life journey. And we do often work quite closely with a number of our palliative care services to refer patients on and make sure that they are linked in with their essential services as part of their end of life journey. We are incredibly privileged to also manage the Regional Access Support Scheme, which does provide some financial remuneration and support for patients to travel to a practitioner, or for a practitioner to travel to a person in rural and regional WA where there are no local practitioners available in their area. And that has been an absolute gift to us in supporting equity and access across Western Australia. And certainly we've seen quite a significant uptake, particularly for practitioner travel to a patient across our regions, because in general cases, patients are often too unwell to travel for care by the time they are exploring access to VAD. We do provide our care wherever it's needed, however it's needed. So we will travel anywhere across WA, from Kununurra to Warburton to Albany, and do that routinely, providing care to patients face-to-face where that's appropriate, by telephone, email or video conference within the constraints of the Commonwealth Criminal Code. And we will see people in hospital, in their home, in their residential aged care facility, wherever is the most appropriate place for the person to be if they need us. So I think we've already probably heard quite a bit about the demand that we've experienced in Western Australia, and that being a little bit higher than what we had predicted that it would be. And I will touch on that again a little bit later. But in terms of the work that the Navigator service has done so far, we are actually well over 500 contacts to our service for support, and the majority of those contacts are from people or from family members or support parties seeking support for a particular person, and our demand does seem to be continuing to grow. Age range of people has been between 21 to 101, mostly sitting around about the mid-70s. Boys and girls, pretty fairly even split, with no one self-describing to us at this stage. Just under 60% do have a malignancy or a cancer of some sort, and just under 20% have a neurodegenerative condition, most significantly the patients with motor neurone disease, who you'll probably hear a little bit about later on today. Almost 90% of patients require ongoing care from us, so our care exceeds over and above just that initial phone call for someone seeking information and support. And we do walk with patients and their families as much or as little as they need us throughout their entire VAD journey, if that's what they would like, including being present at their death and providing bereavement support to families afterwards. We have supported people across all regions in Western Australia and are continuing to provide care across all places in our gorgeous state. And I would say that for most people, from the time they contact us until the substance is available to them is usually around about 4 weeks, although we have got patients who choose to take a much more leisurely approach to it and take many, many months to work their way through the journey. And we have had a number of patients who have needed to work through it a little bit faster, either because their disease was outpacing them, or there's potential things around loss of capacity, or they just want to work through the process as quickly as they legally can to ensure that it's available to them if and when they require it, and the sense of relief that that often brings with it. Whether or not that's a conversation with a person with their GP, contacts to us, conversations in the community, it's definitely something where people are very much making their voices heard. And I think when Scott talks about this being legislation for people in Western Australia and making sure we are doing the right thing by them, I think it's very, very clear that this is a choice that people have wanted and are relieved to have available to them in Western Australia. We have certainly had a bit of a change in tact. So when I was appointed back in March last year and we started conversations with healthcare providers in this space, it was very much like, we think that at some point in your career, a person may ask you for support or ask questions about VAD. When I present to GPs, which I do regularly now, I very much switched that from it's a not if but when a patient will raise that with you. And I would really encourage any of our medical practitioners who are part of today's session to really take some time to have a think about how they might respond to a patient asking for their help or support in this space, because it will happen at some point and probably sooner than you think. I think one of the real privileges of this role is being able to visibly see the real physical relief that people feel in having this choice available to them when they start those first discussions with us. It's definitely quite a remarkable moment. help is available, and I think that that's a really key message for us. We are all finding our way in this new space, but just really want to make sure that anyone who is with us today is aware that there are places you can go to for support, and you certainly can come to the Care Navigator service. Our process is very complex, but it is very systematic, and it's a hard thing to navigate at one of the most challenging times in a person and their family's journey together. So that's why we are here, to help and support you in that space. I would really like to acknowledge that one of the people who do provide amazing support in this space is our VAD trained practitioners. The people who choose to do work in this space are absolutely extraordinary. I've been lucky enough to work in many varied roles in my nursing career, but never have I been so blessed to work with such a varied collection of practitioners and people, GPs, public, private, community services, all over the place. And they are all genuinely amazing humans who firmly place the person at the centre of everything that they do. From our VAD trained doctors, our incredible pharmacist team, and you'll hear from Brenda just shortly, our navigators, who I'm immensely proud of, and our end-of-life care team and the voluntary assisted dying board. They make this a real choice for people in Western Australia every single day. And finally, I did touch up a lot about whether or not this should be my first thing or my last thing, but I'm going to leave you with them. The biggest thing that I have learnt over the last 6 months is about the people who make this choice. And we've heard a lot about the kind of people who would choose access to VAD, about their demographics, how much money they had, where they would live, all sorts of things. But I have to say, as in most things, WA has certainly forged its own path. And more than anything else, what seems for me to unite the people who make this choice in my mind is inherently who they are. This is definitely not a choice for the faint of heart. It's not an easy way out, and it requires immense bravery and courage in the person who chooses to make this decision for themselves at the end of their lives. And what they show me each and every day is their immense strength and certainty. And we hear a lot from their family around the fact that this isn't a surprise that this person has made this decision. And often they are very much, it's part of who they are. They have always wanted to make careful choices and to be in control of things in their life. And their death is absolutely no different from that. And what we hear from the people themselves is their peace and relief they find in knowing that they can have some kind of control over the manner, the timing and the nature of their death, when they're at a time in their life where they have no control over most other things. And I think there is a really core group of people who absolutely needs recognition, almost not above and beyond the person who makes this choice, but the people who choose to support them throughout that journey. The loved ones, the ex-wives, the best friends, the next door neighbours, the children, the carers, all of the people who choose to walk with the person along what can be the most challenging and heartbreaking journey, who make the phone calls, organise the appointments, find the documents I ask them for, a birth certificate that they haven't seen for probably about the last 50 years. And when the time comes, when the person makes the decision that this is something that they want, they make the playlist, they light the candles, they find the outfit, and they hold their hands. These people are absolutely extraordinary, and I am absolutely in awe of them every single day. And I really hope, and I'm sure that some of them are watching us today, because they have just been an immense gift. And I think these people, all of these people, our practitioners, our patients, our families, they remind me every single day about why I want to be a nurse and why I still want to be a nurse this far in my career. So thank you all. That's it from me. Just to know that we are here Monday to Friday, 8:30 to 5, and anyone can contact us, including people sending information or GPs just wanting some help.
Thank you so much, Alice. And Alice has really been an inspiration to so many of us in terms of the approach that she has taken to this pretty significant task. And as you can hear from her presentation today, the focus that she had on the people who are accessing voluntary assisted dying and really supporting them. I'd now like to introduce Ms. Brenda Shum, Acting Chief Pharmacist for North Metropolitan Health Service, where the voluntary assisted dying statewide pharmacy service is based. Welcome. And Brenda will provide an update from the pharmacy service on the first 6 months of voluntary assisted dying.
Thanks, Amanda. So good morning all. In keeping with the theme, I'll be talking about the top 3 things that we really wanted to share with you in regards to our experiences in the first 6 months of nationally. And as I'm hearing my colleagues and their reflections on this time, it's really hard to envisage that it's only been this time that we that this has been able to be accessed, in WA, particularly with everything that we've all encountered in this space. The items I'm going to go through particularly centre around our operations and key things that we'd originally envisaged when we were setting up the service based on the Victorian data. So we've had a number of discussions with our colleagues about why there would be these marked differences, and these are some of the reasons why we think that might be the case. One of the main items is that our legislation is different to the Victorian legislation. So within our legislation, the WA VAD Act stipulates that a patient who elects to proceed down the self-administration pathway must be able to prepare and administer the VAD substance themselves. So this isn't something that's stipulated in the Victorian VAD Act, and this also obviously poses a challenge for some of our patients who have dexterity issues. The other aspect of our legislation is that the WA VAD Act also enables comparatively easier access to the practitioner administration pathway. In terms of our patient demographic, we do have a number of patients whereby in terms of their condition, the oral, PEG, NG routes are not appropriate, so they do need to proceed down intravenous routes. And there's also now a very broad knowledge of the very bitter taste of the VAD substance that's administered through the oral route and is used in both Victoria and WA. And certainly we've had a number of our patients express concerns about proceeding through the oral self-administration route in terms of concerns about their ability to ingest the VAD substance because of this. So throughout the journey that we have with our patients, we provide reassurance and guidance in regards to this and advice on how this can be made more palatable. What I can share at this stage is that based on the feedback that we've received to date, for our patients who've completed the oral route and self-administration pathway, no one has provided any feedback of any issues in terms of the ingestion of that substance. Next slide, please. The other difference that we've seen is the number of supply requests. So Scott and Alice have touched on this as well. So when we were setting up the service originally, we estimated that we would see approximately 1/3 of the number of supply requests Victoria saw within the first 12 months of their service. And this was based on the population differences that we have. What we've actually seen is much higher than this. And really, if we continue on the same patterns of service requests, we will actually exceed what Victoria saw within their first year. The other aspect of supply requests that we've seen is the urgency. So, you would be aware that VAD, needs to be considered process. It's not considered an emergency pathway. But by the point where patients and practitioners are able to reach out to our service to request supply, patients may have had their condition deteriorate to the point where supply is actually required urgently because they, want to access the substance whilst they still have the physical and mental capability to do so. So this has posed a challenge on some occasions for us because of the sheer size of WA, some constraints with flightability as well to our regions, particularly during the pandemic period. And our team, similar to Alice's team, have travelled all the way up to Broome and down to Albany and multiple places in between to supply the VAD substance to patients and practitioners. Our patients have shown a very strong preference for us to visit them to provide the VAD substance. And we've created, very strong relationships with our practitioners such that we've seen, equivalent numbers either come to our service or for us to go out to them. And today we have managed to meet our KPIs for supply within both metro and rural areas. So looking forward into the last few months of this year and, in our future state, our focus has really been on sustainability to enable us to continue to provide a service to all of our patients, particularly with the significantly higher than expected activity rates that we're seeing. What we do as well is continue to collect and consider the absolutely invaluable feedback we have received in regards to the VAD substance protocols, our service operations and how we can better support our patients and practitioners as well. And on behalf of the SWIPS team, I would like to sincerely thank our patients, their families and carers and practitioners for sharing their journeys with VAD with us and this feedback, particularly noting how emotionally challenging that's been. So on a final note, similar to Alice, I'd like to share our contact details again. It remains an absolute privilege for us to be able to walk the VAD journey with our patients and practitioners And please don't ever hesitate to contact us. We are here to help.
Thank you so much, Brenda, and thank you for your calm leadership and your attention to detail. You and your team at the Statewide Pharmacy Service are really providing everything that we could have anticipated in terms of responding to the needs of people and practitioners to be able to access the voluntary assisted dying of substance in a timely way and to have a lot of support around how they do that. So thank you so much. We're going to move now into the Q&A panel. So I'll invite Dr. Scott Blackwell and Alice Herring to join us back at the table.
No, that's absolutely right.
I think we're all in view. Someone please wave at us if we're not. Fantastic. Thank you so much all for your willingness to take some questions from the attendees who we have online today. As I said at the beginning, we've had questions sent through to us by email before the session today, so we'll start with those. We've also had a couple of questions that have come through during the session, and if we've got time, we'll address those ones as well. We absolutely recognise that it can be a little bit hard to know in this sort of panel context who is speaking. So if you think it's not immediately obvious, panel members, that you're speaking, can you wave or give some movement of your body that will indicate that it is you that is speaking? And that will really help people who are watching to be able to connect with what you're saying. I'm going to start with a couple of questions for Scott in your role as chair of the VAD board. The first one is how many people who've applied for VAD have been rejected and for what reasons?
Yeah, this is a difficult question to answer because we don't really get to know at the board level why people may have not continued with the process. We know, internationally across jurisdictions that generally there's a third sort of formula that occurs that from people who start at the beginning and make a first request. A third of them don't get through the process to the point of prescription, and then of people who get to a point of getting prescription, another third don't actually die from taking the voluntary assisted dying substance. And there are various reasons for that, and quite often it's loss of capacity. The person dies quite quickly and suddenly before they can take the voluntary assisted dying substance. As far as people rejected or found ineligible is probably a better way of looking at it. I actually don't have an idea of that number in my head.
At this stage. Thank you for giving the overview of how this normally works. Another question for you, Scott. Many people, as you would be aware, are keen to have more insight into the demand for voluntary assisted dying in WA. Are there any plans for the board to release information prior to the first annual report that's due at the end of the year? You touched on this a bit in your presentation.
Yeah, look, we've developed a process. We thought when Roger Cook was still minister that we should keep him informed every 3 or 4 months, and we did, and hence those 4-month figures ending up in Parliament. We're going through the same process with the current minister at the moment, who we will meet with soon. And I think we need, because of the sensitivity of this, and it's still early days, and it's still politically still a very sensitive thing, and we need to honour that in terms of the position we might put the politicians in who've worked very hard to develop this service for people. So I think probably in a roundabout sort of way I've not answered your question.
But no, I think you provided the information you can. Thank you very much. The third question for you, Scott, is knowing which palliative care, aged care and other health facilities do not support VAD on their premises is important information for many people at the end of life. Is the VAD board able to make publicly available a list of palliative care, aged care and other health care facilities that do not support VAD to help people make informed decisions?
Look, it's not something that we would choose to do, and there's very good reason for that, because voluntary assisted dying is a choice for a person, and that person may be connected to any one of the people or services that you've mentioned, and it's a case-by-case phenomenon. And we're finding already that services, although they may have a set mantra that they follow, that in a case-by-case circumstance, the outcome may turn out differently. And I think it would actually be wrong to actually do that, both for the people and for the services themselves. We've seen across the world that there's been a time for voluntary assisted dying to need to settle into a community, into the health services that exist, so that people find their place with it eventually, and without compromising their beliefs.
Thank you very much. For those who might have just dialed in, we've got a panel session with Dr. Scott Blackwell, Chair of the VAD Board, Alice Herring from the Care Navigator Service, and Brenda Shum from the Statewide Pharmacy Service. And we're just asking them some of the questions that have been submitted to us by email before the session started today. Alice, it's your turn now. The first question for you is, how important is it for the Care Navigator Service to be involved with coordination of care? Should it be encouraged in the early phase for the Care Navigator Service to be involved with every patient, or is there room for local processes, particularly in regional areas?
I think both. Obviously, I'm very passionate about our service, and I do think we add real value to the journey of the people that we care for. What we're finding now is we're having a lot of contacts with patients, maybe quite some months ago, where they were initially seeking information. They're coming back to us now. They've had time to consider it, and their disease has progressed, and we're able to support them moving forward through the next journey. So I absolutely would encourage people to reach out to us early and to engage with the Care Navigator Service early on in their thought process around this, because we will be in a position to help provide them with the right information that they might need to inform their decision making. And we do, noting that we are still very much in its infancy of VAD in Western Australia, we do hold a lot of the shared experiences and knowledge in that space that are probably going to be in a good space to support people through this journey. Absolutely, we couldn't do the work that we do without the incredible support that people receive locally in regional WA, and you will hear from Fiona Jane later on in the panel from down in the Great Southern, and those assets are incredibly valuable. And I think it harks back to what Scott mentioned about the relationships people often have with their care providers who are already supporting their journey. So I don't think it's a one or the other choice. I think you can absolutely choose to engage with the Care Navigator Service, and we can work quite closely with people's local providers with the person's consent to make sure that everyone is on the same page and helping support the patient through that journey, wherever it is they need it, whenever it is that they need it.
Thanks, Alice. You talked in your presentation around the Regional Access Support Scheme, and the question that we've asked is that there have been many questions coming through regarding this scheme, which the Care Navigator Service manages. Can you explain further how the Regional Access Support Scheme, which is abbreviated to the RAS, we managed at least one acronym that's easy to say, who has been accessing it, what constitutes a local practitioner for a regional patient, and how you go about determining if a patient is unable to travel?
Sure. So you have to remind me, Matt, if I lose track with the three-part notion.
Yep. So who's been accessing it, what constitutes a local practitioner, and how do you determine if a patient's unable to travel?
So far and away, the RAS has been predominantly used for practitioner travel to a person. And I think that comes back to something that I mentioned in my presentation when I talked about the RAS around the nature of the person at the time of their life and their ability to physically travel potentially quite some distances in Western Australia to see a practitioner. We have been incredibly blessed by the practitioners who have chosen to do the training and have been willing to provide that support from patients, leave their busy clinics, take some time off from work to travel to physically be the patient for that journey. We tend to find patients usually will need about 2 trips through the RAS, sometimes 3, sometimes 1, and a lot of that is to do with the care that we can and cannot provide via video conference within the constraints of the Commonwealth Criminal Code, but all very different. In terms of what constitutes a local practitioner, obviously we're usually talking about someone available within the patient's region, but recognising that the regions in Western Australia are large, so it's about a reasonable conversation about what would be feasible for that practitioner to travel. What was part C in there?
How you go about determining if a patient is unable to travel, which you've covered a bit already.
I think it's very much about a conversation with the person and their family and with the practitioner about what's reasonable and what's possible.
Yes. Yeah. Thank you very much. Always love a multi-part question. The final question for you for now, Alice, is what, if any, are the complications or issues related to someone who's receiving home-based palliative care and also choosing to access voluntary assisted dying?
Yeah, I don't know that there are any. What I would say is a heartfelt thanks to our colleagues in palliative care, particularly those providing care in the community, who are at times shouldering an increased workload in this space and having to devote more time and energy and effort in supporting patients in the VAD space, whilst their primary focus is absolutely wholeheartedly palliative care. But I don't think VAD is ever intended to be an island, and nor should it be. And absolutely, we would actively encourage and do actively encourage patients to actively engage in palliative care and receive their immense support throughout their end-of-life journey, along with the care that they receive from their GPs, from their other treating specialists and other services supporting them. So I wouldn't ever say that having a patient receive palliative care in the community is any kind of blocker to accessing VAD, and usually those two things work beautifully together for the person.
Thanks so much, Alice. Brenda, there's a couple of questions that have come in prior to the session for you. The first one is that the Act specifies the process for a patient to switch from self-administration to practitioner administration and vice versa, and this seems to be straightforward. In practice, how quickly can this change be accomplished?
Yeah, look, great question, Amanda. So what we've seen, and we actually have seen a few patients, not many, a handful of patients who've had to switch. And the main reason why is, sort of that change in patient condition that I was talking about, which can happen very quickly and unexpectedly as well. So we've seen it occur literally within 1 to 2 days, so very, very quick. And, that goes just to show, I think, how efficient, the processes are associated with that.
Thank you very much. The second question for you is, how much of a priority is it for providers to arrange for safe storage of VAD substances on site at an aged care facility? The questioner's understanding is that other providers have had the VAD substance delivered on the day it was being administered, so did not need to arrange for its storage at the facility.
Yeah, so look, with that question, Amanda, it goes back to, I guess, the organisation's position in terms of risk, and I guess what we refer to as the potential for diversion of the VAD substances. So it can be different in terms of the organisation's position from organisation to organisation. So we would advise that they consider what they're comfortable with in terms of their risk appetite. And certainly, as acknowledged in that question, we have had cases where we've seen the patient, and as we're exiting, the patient is preparing to self-administer or be administered the substance.
Thank you. And the third question for you is around the same type of topic. Have there been any problems with the VAD substance being kept in the home of people who intend to self-administer? Have there been any issues with the length of time that the substance is left in the home before it's taken?
Yeah, so with the first part of that question, certainly, no, we've not had any feedback there's been any issue. What we do as part of our counselling, when we talk through with patients, and we, I did this myself at a visit recently, is go through where the patient intends to keep it, make sure it's a safe area, make sure, the storage conditions can be met. We'll happily view it and provide advice on that as well, but certainly we haven't had any feedback that that's been an issue from like a security or condition point of view. And in terms of the duration as well, no, we've not had that feedback. So that is really positive for us.
Thank you. And I remember it was certainly an area that we had a lot of focus on in the lead up to the 1st of July and worked a lot with providers around this. So it's really pleasing to hear that it's working much as you would expect. The next question is for all of our panel members to contribute to. So please do remember to indicate if you're speaking. And the question is, what challenges and solutions did you find to negotiate the federal law about not using telecommunication to discuss or share suicide-related material? Brenda, I think you might have a particular perspective on this one.
Yeah, so particularly in terms of the VAD substance protocols, and obviously the substances names themselves, which is one of the core duties and roles and responsibilities of my team. I'll have to say it has been challenging, and certainly we've been advocating for changes to that legislation to be made so we can, provide care more, I guess, increase accessibility in terms of that transmission of information, particularly to colleagues, and particularly what we're seeing in terms of other states and territories passing through VAD legislation and going through that setup process, but also to our patients, and particularly with the pandemic environment. So for us, it is centred on, making sure we have clear guidance for our team, but also provide supports to patients and practitioners in terms of transmitting that information, providing, mechanisms so unfortunately, hard copies at this stage of that information that can be shared and disseminated.
Fantastic, thank you. Alice and Scott, is there anything that you'd want to add around that
Look,
question?
the board has actually, does have this item on its agenda and has done throughout. And at the moment, we're working through the minister to encourage the minister, state minister to work with other state ministers to work on the Commonwealth. You know, we know the political process will be fairly long term, but I think unless it happens at that level, then change probably won't happen at all. But I think as we are seeing more and more states move in the direction of having voluntary assisted dying, then I think we will see that this is the right process, and we'd encourage those who are watching from other states to work through their ministers as well. If we get enough state ministers sort of hitting on the federal minister, we might get somewhere. And we've got an election coming up as well, but we won't talk about that.
Thanks, Scott. Alice, there's a question that come through live for you, but before we go to that, I'll just check if there's anything you wanted to add around this question.
No, probably just ongoing support for our practitioners in working through what it is possible and not possible to say by video conference, and absolutely utilising the regional access support scheme to provide the capacity for face-to-face care provision where it's not possible by video conference.
Thank you. So we'll move now to some of the questions that have come in during the session, and many thanks to everybody who has put a question, and we'll get to as many as we can, and we'll focus on the questions that I guess shed the most light for people around how services and structures and systems are working in practice. So the question for you, Alice, is around bereavement support. What does bereavement support from the care navigators look like?
Yeah, it's very varied. So just like the care we provide for a person throughout their VAD journey is very varied, so is the bereavement support we provide, because it's important that we recognise that people want different things from us, families want different things from us, and our relationship is different, and often they do already have pre-existing relationships with providers who are already in the right space to provide that bereavement support. Generally, what we will do is offer a number of phone calls to the family in the immediate period after the person has died, and then more ongoing follow-up. And we do very much encourage them to reach out to us for any kind of care and support they need in that space, and ensure that the family do have access to our contact number and our contact details, and know that they can talk to us at any time, whether or not that's, you know, the week after the fact that someone they love has died, or if it's 6 months or 12 months down the track, that we will still be here and still available to them for help and support. We do have a lot of those phone conversations with different family based on what they want, where they're at in their grieving process. We do often send cards as well, which again is just a tangible way to let people know that we're here for help and support if they do want to talk to us at any future point.
Thanks so much, Alice. The next question that came through was around the number of practitioners and where they are in WA, and I'm happy to speak to that from the department's point of view because we manage that part of the process, but please, other panel members, feel free to leap in around this. So Scott presented data on the first 4 months of practitioners. I can give you an update from last Friday, the 4th of February. At that time, we had 56 fully trained practitioners who had completed all aspects of the online training and other requirements. 39 of those practitioners are in Perth and Peel, and we've got a growing number in regions, particularly in Southwest, Great Southern, excuse me, and Kimberley. We can't give numbers of individual practitioners once that starts to get down to less than 5, because we are really aware of wanting to protect the privacy of practitioners, particularly in rural areas and centres. But I hope that that gives you a picture around that distribution, and certainly the department is working to continue to raise awareness around voluntary assisted dying for all practitioners, and to provide opportunities for practitioners to be able to complete the training should they choose to do that. I'll move to the next question. This is one really for the whole panel, and I think it's a question that we've all been asking ourselves a bit, and some of you touched on it a little bit already in your presentations. What is the reason or reasons for WA uptake being significantly higher than Victoria's at this point in time? Any thoughts?
Yeah, look, if I can go first on that one, I think probably part of it is because Victoria went first, and so it wasn't necessarily a new thing. It had been talked about and so on. I think that does have something to do with it. I think clearly our legislation And we learned a lot from the Victorians. They were so good to us during the development of our legislation. And so I think our legislation enabled us to get past some of the blocks that are in the Victorian legislation. And this is an ongoing thing throughout Australia, that we all help the next come off the ranks. So I think the legislation got better because of that. So a lot of it goes back to Victoria. But I think it also reflects that feeling we got from the people back in the ministerial expert panel days. And when we went out there, Amanda, if you remember, it was really palpable that this was something that West Australians wanted. So I think we've just seen a reflection of what the true desire was now. And I'm happy that we provided legislation that enabled that, as I said earlier in my talk, in a way that they get access, but safely.
Thanks, Scott. Brenda and Alice, is there anything that you'd like to add to that?
Look, I completely agree with Scott. I think it's part of, that understanding that that has become an end-of-life care choice. And certainly we're seeing that nationally, internationally, and I 100% agree that Victoria went first. We had so many learnings from our Victorian colleagues. We're able to bring that into our services.
And yeah, I think the 1st of July came at a really fortuitous time for us, and that it was right when there was a number of other states having these conversations. So VAD was very visible in the media. There was a lot of conversations around that were very, very visible. And I think Western Australia certainly has benefited from that being a topic of conversation at the pub or the coffee shop, where people were becoming more and more aware that it was an available option for them.
Absolutely. So it reflects the bigger picture as well as the WA specific picture. Thank you all. Brenda, a question for you. Have you ever had to deliver the VAD substance to a patient after hours? And if so, how often?
Okay, well, we have, but not particularly often at all. So, we do consider each patient, particularly circumstances like that, on a case-by-case basis. And, it goes back to flagging that we've now seen a number of patients where supplies were required urgently. And so I'll discuss that with the team, I'll discuss that with our colleagues at Department of Health and the VAD board to make sure that we can provide appropriate supports for the patient, but also our staff as well.
Thanks, Brenda. Scott, a question for you. Firstly, a thank you for your presentation, and then a query about whether the take-up of voluntary assisted dying has been more in the metropolitan area or in country areas, and were you surprised with the numbers?
Look, yeah, I guess we were surprised with the numbers. Just the sheer volume of requests was I think a surprise. It wouldn't have surprised me if we were on a per capita basis getting more requests than Victoria for the reasons we've just been talking about. But I think the volume has been, just a real expression of West Australia is unique and different. But I think the thing that sort of probably pops out to me from the work that we've done, and Alice sort of, I think, alluded to this a little in her talk, is in Western Australia, it is a little different. We see people talking about that this is a choice of people who are highly educated, middle class and so on. Here it's across the board. And I think we're seeing a very universal acceptance and application of this choice in Western Australians. And I haven't gone back to look at all the other jurisdictions, but I don't know another jurisdiction who has quite, that sort of outcome as we have. So yes, there have been surprises, and some of them quite, fascinating, really.
And I think that probably leads in beautifully to what will be the final question for this panel session. Is there anything that you wish you had known and didn't prior to commencement? We could take all day on that, but perhaps if we give it a couple of minutes.
Look, I think that I'm glad I didn't know anything that I know now. I'm glad that we paved the way as we did. If I look back, I think, just the sheer contact with the people to bring the people's choice back to them through legislation, all of that is stuff that I look back on, and I think that was just the right way to do it. And I don't know how we fell upon that in Western Australia, but we did. So, I'm still a bit gobsmacked when I think it's about 5 years since they started the parliamentary panel on this through to today, where we're talking about 6 months of activity. It's a long journey, but I have to say it's, I can't think of anything I'd like to do differently, but there have been a few moments.
Inevitably. Brenda, what about you from your perspective? Is there anything that you wish you'd known and didn't prior to commencement?
I have a similar viewpoint on Scott, because sometimes it's better to just not know and forge ahead. But look, in terms of the main components, in terms of the elements, no, not at all. I think, you know, I've said it before, I think particularly the VAD implementation has been a real exemplar of how, you know, our primary care, private institutions, public institutions, Department of Health have worked in concert to try and bring this to our patients across WA. I think I've never seen anything like this before when I've worked in health for over a decade now. And so I think that has been really one of the key reasons why it's been so successful.
The quality of the relationships and the collaboration has
That's
made a
it.
huge difference.
That's it.
Yeah. Alice, how about you?
I think I would really echo what Brenda has just said, in that this has been an absolute gift to be involved in something that has allowed for that space for so many different services to come together and to talk through their positions and to talk through what works and what doesn't work, and really build something really quite unique and really special. And for our services to continue now to build on those relationships and to reverse all of those different places our patients are to get care is something that I really hadn't thought about. Obviously we knew we had the work to do, but I don't think we really recognised the immense gift it is to have that kind of relationship. And I'm really hopeful that moving forward in health, there is more and more opportunities for things to cross, you know, different catchment areas, public versus private, you know, community versus hospital. It's really something that's quite remarkable and really, really special in this space.
Thank you. I think that's a great wrap up from the discussion we've had, and thank you all so much for your contributions today and in the last 6 months and before that. So our second session will provide perspectives about voluntary assisted dying in practice, and our first presentation will be from members of the WA Voluntary Assisted Dying Community of Practice. I'd like to introduce first of all Dr. Simon Towler.
Morning everybody, Kaya.
Current chair of the Community of Practice and also our end of life care clinical lead at the Department of Health. In the middle, Dr. Angela Cooney, member of the Community of Practice and a general practitioner in Perth. And next to me, Dr. Gareth Wahl, member of the Community of Practice and a specialist practitioner based in Perth. I'll hand over to you, Simon, to begin.
Well, thank you for handing over to me, Amanda, but as is typical of community practice members, we've been scheming in the background and we have a plan for this presentation. And Gareth is going to speak first, followed by Angela, then I'm going to finish up. And we look forward to the opportunities to explore questions with people interested today.
Yeah.
Over to you, Gareth.
Cheers. Good morning. We're going to attempt rapid sequence talks today with 5 minutes apiece. As the first speaker, I want to provide an insight into what this experience has been like for me on a personal level, and Angela and Simon will speak about some of the challenges we've had, as well as how the community of practice is evolving. Firstly, I'd like to acknowledge those that came before. I entered this space feeling it was a good thing to do, but with no particular background in end-of-life advocacy. I'm acutely aware that voluntary assisted dying would not be law in Western Australia had it not been for the people who lobbied tirelessly in support of their right to die in the manner that was acceptable to them. Many of them died before this law came to fruition, but what they and their families have achieved has enabled all people today to take a degree of control back in an otherwise very disempowering situation. Similarly, there are a number of my colleagues who've advocated at great personal cost to give people this right to choose. As you'll hear, there are still issues, but I hope that these people who fought tirelessly can feel some satisfaction in seeing how far things have come. My usual place of work is the emergency department at Charles Gardner Hospital. It's safe to say that my work with people in this space has been a dramatic change of scene. I've seen 40 people thus far for assessments, and I've walked most of these people through the process as their coordinating practitioner. I've met people at home, in hospital, in hospice, and in aged care. And in all those locations, I've sat with them and formed what is a relatively brief, but very intense clinical relationship. I've heard stories of intense suffering, of difficulties in navigating a treatment treadmill that they can't see a way to get off, of lives well lived and all too often cut too short. There are countless stories of people watching as this act was debated in Parliament, speaking at length about dying well with their families and friends. Most of these people don't want to die. What ties them all together, though, is that they are already dying, and they're strongly and repeatedly asking for assistance to die in the manner that suits them best. People often have two questions for me when I talk about this. What's it like, and what's the personal cost to you? They also ask, what are the drugs? But we all know that I'm not allowed to tell you that. What is it like? Having previously seen a very large number of unplanned deaths with things left unsaid and with both patient and family profoundly distressed and sometimes in pain, these deaths are the complete opposite. One patient chose to die with no one in the room except myself and my required witness. One person, mostly they've been surrounded by their closest family, on occasion up to 30 of their closest friends. They've been surrounded by love, and most importantly, it's been how they've wanted. These people have died well. What's the personal cost? It's complicated. For me to do this in a way that I think is right, you have to give a bit of yourself to each patient that you see. That does come at a cost, both emotionally and in terms of figuring out how to fit this in with the rest of your life. But what I get back from this is really tremendously professionally satisfying. I walk away from this feeling that I've helped people, and that is something that my patients are giving me that is worth much more than what I'm giving them. So yes, there is a cost, but there's a greater personal and professional gain. Before I hand over to Angela, I just want to acknowledge the brilliant people I've had the chance to work with. A real strength of our community of practice is the involvement of our pharmacy, navigators and program coordinators. I've spent many hours on the phone and in offices with all of these people debriefing, running through cases and figuring out how we best support patients and each other. The team at the VAD board have been thoroughly reasonable in their interactions with me and very accepting of any feedback we've given. We've all learned about the nuances of this process together, and we're still figuring this out. But I can wholeheartedly say it feels like we're on the right track.
Thank you. I have been a GP in Perth for 28 years. That's just background. And we heard earlier that there are 56 fully trained practitioners now, and around about half of those are GPs. So the GPs are the ones who see patients in the community, and often they are people that we've been looking after, caring for and walking with for 20 years. So the GP traditionally offers and likes to believe that we offer cradle to grave care. Some GPs, like a lot of doctors, feel that somebody dying is a failure, that, well, oh my God, we haven't done our job properly. And it's kind of shameful, and we don't like to look too closely at that. You know, because we should be able to fix everything, or else we failed. I don't believe that. I know the people here today don't believe that. It is not failure. I'm not going to abandon my patients just because I can't fix them, just because they're dying, because they won't get better, because death is a part of life. The people here are really special, and you've heard a few people say it today. We are special people. Not everybody can do this work. Not everybody wants to do this work. When the VAD training rollout was announced, I was really excited, and I asked the people I work with, my colleagues, if anyone else was going to sign up for it. And one of them looked at me and said, "Why on earth would I do that? That's really indecent," which shocked me. But like Gareth said, the work we do, we get so much back from it. As much as we put a lot in, it comes back in spades. However, and this is where it gets a little bit curly, the rewards do not extend to the monetary. If you want to get rich, you do not do this job, okay? And that's why we're special too. The state government has been extraordinarily generous in providing for rural and regional services and taking us out there to people who cannot make it into the big city. However, the problem is the federal services. One of my colleagues who's been doing this work for a while estimated that seeing someone through the process from beginning to end takes on average 10 hours, and that's for a very straightforward one. Where it gets more difficult, where there's a lot of input required, it can be a lot more than that. So maybe 16 hours, and only about 4 of those hours are actually going to be direct face-to-face patient contact, because the rest of it is, chasing up specialists to find out about the disease that our patient has and reading up about that disease to see how long it's going to take to kill them, whether they really qualify. We spend hours driving around the suburbs of Perth going to see them because they're too sick to get out to see us. We lie awake at night, or I do. I lie awake at night rehearsing an administration and wondering if I'm going to do it right. We talk to relatives on the phone who are really upset, and we talk to them before the death and after the death, when they're still trying to understand what's happened. Those non-face-to-face interactions are not covered by Medicare. And I found out just a week ago that the Medicare benefits schedule has specifically excluded anything to do with euthanasia. We are allowed to discuss it and counsel about it, and that can raise an MBS reward, but the actual administration is specifically forbidden. So in fact, we might spend 4 hours face-to-face with a person, but only 2 of those hours will actually attract Medicare rebates. That's a big problem for some doctors who they might otherwise do the training, but they know that they've got kids and dogs and mortgages and they've got a busy practice, that they have to pay their staff. They have to pay the receptionists and the nurses and the cleaners, and with the best will in the world, they have to divide their efforts into something that's going to give them some rewards to keep their businesses going. And some people who have started this, doing this work are saying, it's actually getting too tough. I'm spending so much time and my other work is suffering. So some people are going to drop out and some people will never train in the first place because they know it's just not manageable. And some of my specialist colleagues are doing it even harder because for various reasons, they cannot claim Medicare rebates and they're doing all this hard work out of love, and it really is. It sounds strange, we love our patients, we really do. Yes, we can privately bill people. We do it all the time for insurance reports and really trivial things like that. But most of my colleagues say talking about money in relationship to someone who is dying is just really grubby, and we won't do it. We will not talk about it. We will not ask for money, because the last thing the family needs at a time like this is another bill to pay. So it's getting harder to sustain for many of my colleagues. There are not many of us, and there's lots of people and increasing numbers of people who are asking for this service. And the more that people talk, the more we will get asked to do. So I just want people to know that it's not easy. It's a tough gig. Please understand where we're coming from. And lastly, like everybody has said, the pleasure of working with this group of marvellous people, I cannot I can't say enough about that. Thank you to everyone that I work with.
Thanks, Angela, and thank you, Gareth. It's difficult for me to know what to say given the humanity and the grace with which we've both spoken, but I'll try not to slip back into my best bureaucratic speech mode, which many people are familiar with. Just also to give my background, I've been a practicing intensive care specialist for 31 years. Most people would think that would make me extremely familiar with seeing people die. In one sense, you're correct. Of those people admitted to adult ICUs with severe life-threatening illness, about 1 in 10 to 1 in 15 will not survive to go home. But the experience of death in ICU is totally different to my experiences as a VAD provider over the last 6 months. Intensive care, we so often see people with advanced disease who have not made any plans to prepare for their coming death. So often that person has never had a conversation about the prospect that they do not have long to live. When looking after patients with advancing disease, doctors are encouraged to ask the question, do you believe this person will not be alive in 12 months? If the answer is yes, or possibly, it is time to encourage discussion and gently explore with patients the prospect of their life's approaching end. Far too often, though, the clinician will not embrace this approach and care focuses on treatments, often with no prospect of cure and with uncertain benefit. This might be appropriate if the patient's wishes and understanding is that this is how they wish to approach their disease, but most often this is not the case. And sadly, if this is the pathway taken, families will not be ready. And in the ICU, so often the moment is lost when the patient can no longer respond. I did not imagine when I was invited to be part of the ministerial expert panel advising the government on how WA might approach VAD, that I would actually become a VAD provider. I'm still trying to work out how that happened. But after being so deeply involved and having participated in multiple public meetings, as you've heard from Dr. Blackwell, I faced the fact that the community expected that in WA we would successfully implement VAD, and some doctors had to lead off. Despite the resounding public endorsement, there were not many medical practitioners who were going to be early providers. There was clearly a need. But the challenge has been rewarded. From the start, as Angela and Gareth have described, those people who have asked to have access to VAD have been the total opposite to my ICU experience. They have faced up to their coming death, often with courage, but always with a degree of clarity. They know their time is coming. We will all die. For the most part, they have shared their challenges and suffering with loved ones and friends, and they come to the VAD team politely seeking to end their life with just a little bit more control and dignity and with less suffering and pain. As a career, working in ICU has been amazing. I worked with a close-knit team of doctors, nurses and allied health staff and other carers. There is respect and patience in the care of the patients themselves. The experience is very different with VAD. We are deeply involved directly with someone who is fully aware, who openly engages with you as their clinician in decision about their coming death, and most often with the full support for them in their decision with their family. The team in VAD is both different and similar to ICU, multidisciplinary and committed, equally dependent on each other to ensure the quality of care we deliver and to support each other. But the team is not so immediately present as in the hospital setting. So we've made an effort to link up. This is our community practice. We all feel and acknowledge the commitment to patients, but we also commit to colleagues as a support network. What we do in VAD is personally and emotionally demanding. So it is not surprising there is a critical need to share experiences, learn from each other and support each other. The community practice brings together all involved in VAD who wish to participate. We are profoundly privileged, as you've heard, to have the VAD Navigator team, the VAD pharmacy team and our wonderful hospital program directors as part of our community practice. I think you've heard it enough. They're all damned amazing. For the doctors who are from different specialties, are of different ages and who come from different working settings, there is a need for collegiality in this new endeavour. We have an ambition in the community practice to learn from each other and to nurture new providers and to be better and more resilient in what we do. The VAD training emphasised the need for self-care. As a community, we commit to recognising in others the need to take a break from the VAD work. I am amazed by how hard VAD providers are working, driving and striving with little financial reward and putting significant pressure often on their own families. In the end, the energy that drives the community practice comes from the enormous privilege of looking after people who are showing all of us that facing your own death is an important part of living. The patients have given so much more back than we have given to them. They are the heroes in the story and will continue to provide for them even if there are impediments. We respect, admire and applaud every VAD patient. Just on the side, we love the funny stories, the families and the unique time with courageous people. To continue to encourage VAD applicants to remain closely engaged with their usual, we continue to encourage VAD applicants to remain closely engaged with their usual medical practitioners and ensure they are getting access to appropriate palliative care services. I'm deeply appreciative of the ongoing care that is provided by the patient's usual practitioners during the VAD assessment and planning. We cannot provide all these important services. So the VAD community of practice is both a formal and an informal network. We are committed to making it work better and to welcome all providers who become involved in this work. We are looking forward to the emergent national community of practice as other states and territories offer VAD. We can be reached through the VAD Secretariat at the Department of Health, and I am profoundly grateful for their support for the community of practice. When you complete your training medicos, remember to indicate on your apply form to the VAD Secretariat that you would like to become involved with the community of practice. We will contact you. You can also reach me at my email address, which will be provided. Do come and join us. Again, thanks to Angela and Gareth, and thank you to the audience for your time.
Thank you so much, Simon, Angela and Gareth. I think a really fascinating balance of the rewards and the challenges, and they come out so clearly from what you said this morning. Thank you very much. How about we take one of the questions that has come in. We've had a question around whether the majority of practitioners are GPs, and also about the role of nurse practitioners and whether nurse practitioners have signed up.
So I'm happy to start off. I think Angela made the point in her presentation about the current proportion of our VAD providers who are in general practice, and it looks like it's about 50%. And as community practice members, we can't really know because not everybody who's a provider is in the community. But it's very clear that GPs have been very supportive of this initiative. And as you heard both from Alice and from Angela, for those services being provided in rural Western Australia, they're absolutely central to this. It's been really pleasing to see, though, the emergence of regional VAD providers who, on the most part, are in fact from a background in general practice.
With the only issue I can see with the nurse practitioner role is they're essentially only allowed to be the administering practitioner, which I think the complexity there is patients don't want, I've asked a couple of patients this, they don't want administration by someone that they're meeting on that day. I guess there's a possibility for a palliative care nurse practitioner who's been looking after them from a palliative care point of view to take that role on. But I think there'd be a really small number of people who would have already had a relationship with a patient who could then administer in a way that the patient wanted. And ultimately, it's all about what the patients want. That's what we're all here for.
So often we've said in the presentations today that we're learning as we go. My sense, and we've talked a lot about, but hasn't really been discussed, is that often more than one provider are involved with a patient. And if you look at the team model that I was hinting at, it may well be that if you have a working relationship with a nurse practitioner, you may well bring them onto the team, as occurs already in palliative care, as Gareth has hinted at. And I'm not absolutely sure that the person will find themselves necessarily with a different provider. And we do know that one of the great opportunities around having nurse practitioners in the VAD provider role, although there are significant restrictions on the rules around administration, but there's nothing to say that a nurse practitioner who's an eligible trainer cannot be in the environment with a family during a self-administration event. I actually haven't talked about that today, but I've heard great stories about VAD providers just participating when patients do take the substance themselves. And I think this will be a new area for us to learn. I think in meeting the needs of people across this ridiculously large state, I really look forward to that opportunity.
Thanks all. So we're going to go to the video of Dr. Claire Fellingham, who's the clinical lead for voluntary assisted dying at East Metropolitan Health Service here in Perth.
Good morning, everyone, and thank you for inviting me to speak on a subject that I've been passionately involved with since the 1st of February last year, when I took on the role of clinical lead for the implementation of voluntary assisted dying across the East Metro Health Service. Little did I know back then how my involvement would grow and develop, and how many extraordinary relationships I'd make, both personally and professionally, through my work assisting people to die on their own terms. Today, I'd like to present a case study of one of the many that I've been involved with. I think this case captures many of the common themes that I see in people's reasons for choosing to access voluntary assisted dying, but it also clearly demonstrates just how much voluntary assisted dying is a supportive and patient-centred process. Now, first of all, I'd like to offer you some background information and some interesting numbers from our work at East Metro. I'll then present the case study and offer you some reflections from my own personal learnings. So, like most people across WA, since the 1st of July, when voluntary assisted dying became a legal option for people in the end stages of their life, we have been unexpectedly busy. Demand for service is very great, and certainly the community awareness and expectations regarding access to what is rightfully allowed under the Act is very high. At East Metro, we've supported over 50 patients at some stage of the journey of voluntary assisted dying, and that's not just people seeking information or asking questions, that's actually people who are at some point on the journey of assessment from beginning to end. Our patients have ranged in age from 47 to 99 years old, with slightly more women than men being interested in embarking on the process. Now, we seem to have this interesting law of 50%, that about 50% of our patients have an oncological or hematological diagnosis. Now, that's actually quite low, tends to be around about 80% across Australia, and that's partly reflective of East Metro having a lot of involvement with patients with motor neuron disease, and so we have a disproportionate number of patients with a neurological diagnosis being referred for our services. Approximately 50% of patients are referred to us directly by our palliative care colleagues, and approximately 50% of our patients are located at some stage on their voluntary assisted dying journey at Hospice, which, given that it only has 24 beds, places a huge burden of responsibility and is something that we try and support and very, very carefully manage. Of the 50 patients that we've supported, we have had 10 inpatient and 4 community supported administrations. That means practitioners involved with the patients have supported them in the community. And of course, there being a preparation for self-administration, there probably have been significantly more self-administrations in the community, which no medical practitioners have been involved with. So the case study I'd like to offer you today is that of Mrs. L.N., a feisty and very independent 81-year-old woman who was so well up until the time that I met her that she was actually living at home, caring for her elderly but not particularly demented husband, and who had actually no significant past medical history and was enjoying a really very good quality of life. This all came as a bit of a shock when she was diagnosed in November of last year with a cecal cancer, which unfortunately at presentation was metastatic to liver and lungs. After lengthy discussions between herself, her family, general surgeons and oncologists, where it was made clear that there were no curative intent treatment options for her and all options would be palliative, she decided to actually decline all interventions and just continue to live her life as she had been. Unfortunately, this only lasted a brief while because she was readmitted to Royal Perth Hospital about a month after discharge with an atraumatic hip fracture. She'd simply stood up from a chair, felt her left hip give way, and unfortunately an X-ray in the emergency department had confirmed a fractured neck of femur. Now, typically these are fixed operatively with it is known as a palliative procedure. And the reason for that being that it's a fairly bleak and grim outlook otherwise. The patient is essentially rendered bedbound and then tends to succumb to the consequences of being bedbound. So a septic process from a pneumonic process or from a pressure sore or DVT-PE. Now, despite this being made quite clear to her, the patient declined surgical intervention in this case and instead rather surprised the orthopaedic team by instead requesting voluntary assisted dying, and told them that this was something that she'd actually been exploring in the community and she decided that this was for her. The orthopaedic surgeons were sort of a bit flummoxed by this and noted that in the context of her evolving jaundice and with a bilirubin rising and that probably meant something rather important too. And they decided to refer her on in the first instance to our acute pain service for pain relief of her hip fracture. Now, unfortunately, she was admitted on a Friday, so that referral didn't take place or didn't get acted on until the Monday morning. But she was fairly promptly seen and had a femoral nerve catheter inserted, which through the administration of a continuous infusion of ropivacaine gave her really good quality pain relief from her fracture. She was also referred to our palliative care specialists, and they also saw her and offered her everything within the remit of their speciality. She again made a clear request to them to be seen and assessed for voluntary assisted dying. And with the close liaison with our programme manager, she was referred that same day. And again, restated that she'd had community contact and she was absolutely certain this is the pathway that she wanted to take. Now, I was at work that day and the programme manager got in contact with me and asked if I'd be in a position to accept her first request and act as her coordinating practitioner. So I went up to the ward at the end of the working day and saw the patient, had a lovely conversation with her. She was a very engaging and bright and sparkly woman, and I gladly accepted her first request. The next day she was transferred to Kalamunda Hospital for what was considered to be end-of-life care in one way or another. And I went out and saw her the following day and conducted the first assessment for eligibility for access to voluntary assisted dying. And during the sort of 1 to 1 hour conversation, one and a half hour conversation I had with her, supported by her niece, she was very, very clear in her statements and in her wishes that she had thought long and hard about voluntary assisted dying and she wanted to go ahead. We managed to find a consulting practitioner for her who came out and saw her a couple of days later, and he also found her to be eligible and fulfill all of the criteria for access. Now, during both of these assessments, the patient was very calm, very chatty, happy that the process was underway, but in no sort of great rush to move the process along. She just wanted to know that it was available to her and that we were progressing forward. 17th of December was a Friday, and we agreed that we'd touch base the following Monday. Unfortunately, over the course of the weekend, things deteriorated, and actually the patient's symptoms, particularly in relation to the jaundice, she started to develop some pain. Her pruritus was becoming unmanageable and she was becoming quite nauseous, and she urgently requested to expedite the process, such that we managed to organise for her written declaration to be undertaken the following day. And again, at the written declaration, it was quite clear that the woman that we'd all met a week or so previously was deteriorating quite rapidly now. The sparkle had gone from her eyes and she was becoming more lethargic, more sleepy, still very, very much in charge of all of her mental faculties and able to make decisions, but definitely deteriorating. So much so that I went out the following morning and conducted a final request and a final review. And the patient was very, very keen that we should progress on and make the administration decision, and I should write the prescription and courier that to the pharmacy straight away, because she was quite mindful of the Christmas period approaching and mindful of services closing down. As you know, voluntary assisted dying is an intentional process, it's not an emergency, and as such it's not provided over weekends or across public holidays. So she was very keen that we should get everything in place. I duly did drop off the prescription, and in fact so keen was the patient that she decided on administration later on that afternoon. Key factors with this lady were that she had 3 adult children, a husband and a niece, and they were all very supportive of her decision. And we don't always see this, but it is wonderful and makes life so much easier when patients are very, very well supported by their loved ones. Part of the reason that they were able to support her was that they could see that the person that they knew and loved had deteriorated. Her clinical picture was very obvious now. She was a very, very bright shade of yellow, really quite consumed by nausea and itchiness, and with the evolving hepatic failure becoming more and more sleepy, and really worrying that her capacity was going to fluctuate or be lost, such that her ability to access voluntary assisted dying would no longer be possible. The patient herself was also very mindful of Christmas approaching and didn't want, she could see, she could feel the end of her natural life approaching, and she just didn't want for the lasting legacy of her death to be that, along with the joy that comes with Christmas approaching, would always be tainted by sadness for her family. She was very worried about dying on one of the significant days of Christmas, and so she chose to expedite her administration to prevent this from happening. Such was her level of calm and pragmatism surrounding voluntary assisted dying that she developed a very good rapport with some of the junior doctors looking after her, and they had a natural curiosity in relation to voluntary assisted dying and actually asked the patient and her family if they could be present during the administration and during the period of her death, and the patient very kindly agreed to allow them to. And I think this case really demonstrates how voluntary assisted dying is an entirely patient-focused process. She was supported in every respect from the very beginning, when she was offered specialist treatment in the context of her initial diagnosis from the general surgeons and the oncologists, who presented a range of options to her. And as a patient with full decision-making capacity, she was well within her rights to refuse all of those treatment options. Then, in the context of her complication, she was offered orthopaedic intervention, and again, on the balance of informed consent, she chose to refuse all of those. And the one thing that she did choose to accept, which actually helped very much and was in place for the full 10 days until she died, offering excellent pain relief, was the femoral nerve catheter from the acute pain service. She was supported by our palliative care team, who saw her during her acute admission to Royal Perth Hospital, and then of course looked after her with all of the wonderful and excellent supportive care that a hospice admission under a palliative care consultant specialist can provide. The process of voluntary assisted dying was driven at the patient's pace. It stopped and it started, and it moved slowly at the beginning and then quickly at the end, as was what was required from the evolution of her disease process. And at all times it was collaborative and respectful. My personal reflections on not just this case, but all the cases I've been involved with are that clearly the death of a loved one is never a good thing, but voluntary assisted dying can offer a good death. And in the vast majority of cases, reflections that we get from patients and from their families afterwards, because we follow everybody up with full bereavement care as per any death in hospital, are that, overwhelmingly voluntary assisted dying deaths are peaceful, they're dignified, they're calm, they're gentle, and they're compassionate, and they are truly, truly patient-centred. Personally, I found it an immense privilege to be involved so deeply and intimately in another person's life. And experiences that I've gained and conversations that I've had with people and what they've imparted in me has allowed me to cherish the time that I have and appreciate my own life even more. I now choose to live more deliberately and actively look to seek out the joy in everything. And that is with an immense debt of gratitude to all the people who've shared all of their experiences with me. And I'm very grateful to them and to you for listening. Thank you.
Thank you so much, Claire, for your compassion and for your really thoughtful overview and for talking about your learnings as well. And thank you for your foresight. I'd now like to introduce Fiona Jane, who I can see on the screen. Fiona is the Clinical Hospice Manager at Albany Community Hospice, and we're so grateful to Fiona for being willing to provide her perspective on the first 6 months of voluntary assisted dying. Thanks, Fiona, over to you.
Thanks very much, Amanda, and thanks everyone for the opportunity to speak with you all today. I just wanted to give everybody a bit of a background about who we are. So Albany Community Hospice has been providing palliative care in a home-like environment to residents of the Great Southern for 32 years. We're a not-for-profit, non-denominational 8-bed inpatient palliative care unit, and we're licensed as a private hospital with a small team of 43 employees and an active and supportive group of 40 volunteers. So we partner with WA Country Health, Great Southern, private healthcare providers and DVA to provide specialist palliative care free of charge to people in the Great Southern region, and we're supported by generous fundraising and support from our local community. Our mission is to be a leader in provision of expert palliative care, end-of-life choices, education and support so that all members of the community can experience death with grace in a manner and a place of their choice. So in the past 6 months, we've cared for 109 patients and their families. 45% of these went home or moved to residential care, and the remainder died here at hospice. Our average length of stay at hospice in the last 6 months has been 7 to 10 days. And prior to July 2021, hospice acknowledged the diversity of opinion in public and healthcare communities about voluntary assisted dying in the end-of-life care setting. And there was no information for us as a community-based hospice to base an informed decision about whether it would be acceptable for our community to support VAD here at hospice. So as a result, we conducted a research project which considered the feedback given in community consultation with staff and from staff and volunteers, which informed our board's decision that from July 2021, eligible patients who chose voluntary assisted dying would be permitted to access it whilst being a patient here. So for anyone who's interested, the research paper is available on our website to share. In terms of our VAD stats from July to December last year, we had, as I said, 109 patients admitted to hospice. The total VAD first requests we received were 8. Of those, there were 5 with a malignant diagnosis and 3 with a non-malignant diagnosis. And these resulted in 4 practitioner-assisted, voluntary assisted dying deaths. 2 of these were here in hospice and 2 were in the community. There were no self-administered VAD deaths that we assisted or supported. And of these deaths, 2 died during the initial assessment process and 1 died following the completion of the assessment process before the VAD substance was supplied. And we found our average timeline from first request to administration was from 12 to 21 days. So I've been asked to just bring up what the top 3 things we would want people to know about the first 6 months of VAD in regional WA. And the first thing, most importantly, we feel is that palliative care and voluntary assisted dying can and do intersect. So symptom control and preparation for the end of life still continue to be the top priority in caring for all patients, regardless of whether they make a VAD request or not. Symptoms continue to be managed with the same attention to the physical, psychological, social and existential needs of the patient and of their family. And the patient remains at the centre of their care, and their goals of care are clearly identified by them as they are admitted here to hospice. At hospice, we place great importance on patients feeling safe. Those staff and patients, for cultural, religious or other reasons, who are opposed to VAD are assured of our commitment to the provision of continuous expert palliative care to all patients. Staff are supported to continue to provide palliative care and choose the level of involvement in caring for a patient undergoing a VAD request and assessment process. We have developed operational guidelines to facilitate VAD in a safe manner for all involved, which has worked well. In our experience of VAD requesting patients, we've seen improved patient-related symptom control of previously difficult to manage symptoms such as fatigue and anxiety, and this has happened almost as soon as the first assessment has been completed. The process of VAD assessment acknowledges suffering caused by the burden of the disease process, and the patient feels heard, that their fear of increased debility, suffering and being a burden on their family, it's acknowledged. We also found that extra psychological and emotional support was necessary for the patient and their family or carer regarding themes such as having a VAD request or assessment declined, or fear that the patient would die before receiving VAD. These concerns impacted on the team caring for them all, and has all become involved about the intent of supporting the person in their final choices. So formal team debriefs have been held from the very first VAD administration here, and several less formal debriefings have followed after this, where these themes and other themes are discussed, and all of this has helped to improve how we do things and support each other and patients and their families and carers going forward. In the past 6 months, we've had VAD trained medical practitioners who supported patient requests coming from outside our region, referred by the Statewide Care Navigator. This, of course, required temporary credentialing approvals and orientation to the organisation and culture and our site-centric voluntary assisted dying guidelines. There needed to be connection with the medical practitioner already providing medical governance of the patient, and the sharing of relevant clinical information and the inclusion of the clinical team, keeping the patient, the family and carer and the team informed and supported through this process. So to manage this, we created a role as a VAD program manager, which acts as a link and a liaison between the patient and their GP, the VAD coordinating practitioner and the team providing care here at Hospice. This role consists of following up and arranging consults between GP, providing medical governance, and coordinating practitioner, their family and patient and family carer, and keeping everyone informed of their progress, process, and the outcomes. We saw that collaborative and open relationships between the GP and the VAD coordinating practitioner have needed to be developed and fostered in sharing care regarding governance of day-to-day management of the patient, their family and carer during this request and assessment process up until and after administration and death for things such as prescribing anxiolytic medications as needed, discussions whether a medical management plan for a patient deteriorating and choosing to wean off opiates for pain control is possible to maintain capacity for them to meet their final request, who would provide the death certificate, and practical issues such as who would provide venous access prior to discharge home, or who would prescribe home oxygen for a patient returning home for a practitioner-assisted, voluntary assisted death in the community. In cases where the practitioner travelled to Albany to assess or administer the VAD substance, increased coordination between all parties was required and timeframes became extended due to external commitments of the practitioners. In these past 6 months, all VAD trained practitioners have all been very dedicated to help support patients in their choice to request VAD, and often consultations have been on weekends and after hours. Thankfully now we have a very small number of local practitioners available to support requests for VAD here, and this has made it a lot easier for everyone involved. So the second point I'd like to bring up is the use of telehealth in voluntary assisted dying assessments and processes. So telehealth was used in nearly all cases for the consulting assessment here at Hospice, and some patients in this timeframe had been seen previously by the consulting practitioner in palliative care reviews, which made it a lot easier in terms of a rapport and a relationship and a prior knowledge. The VAD program manager sent relative clinical case information to assist with the assessment and liaised with the patient and the doctor to set up the meeting. Any patient who was unfamiliar with technology or had a hearing or a visual impairment was supported, and their support person was always encouraged to be present so that questions or concerns could be answered. Some of these patients preferred to use their own phone and managed the consultation on their own. Emails, text messaging, scanning documents were also used to ensure smooth operations, and the VAD program manager coordinated these. These are still being used despite having locally available VAD practitioners, as they do assist in expediting processes, but require a dedicated VAD program manager to ensure completion and coordination in a timely manner. And the third point that I'd just like to bring up is what we've noticed was an increased attention to detail in people's end-of-life care plans and planning. So we know that talking about end of life and helping our patients and their families prepare for end of life is something we do well and routinely in palliative care. However, in the past 6 months with the VAD practitioner administrations we've had here, we've seen particular attention of each individual exploring what would be their own personalised ritual of the act of dying, with attention to the details of the day of VAD administration. We found the VAD planning for death form found on the WA guidelines to be very useful and has been used in 3 of the 4 VAD deaths here at Hospice. It's been valuable to assist and support conversations around this process, and it's helped the patient and their family and carer prepare for their death. And it's also helped our clinical team support emotional and physical preparations. Whilst very practical, it can also be a very overwhelming conversation for the family and the family carer and the patient to contemplate and plan, and has required a facilitator with skills in supporting such conversations. Details we've heard are to choose who will be present at the administration and when and where this will occur. Personal details such as what music will be playing, what they will be wearing, or objects meaningful to them that they will be holding. Our team supporting patients on the VAD pathway and witnessing their death have commented on how very different this is compared to the gradual deterioration of consciousness and control leading into the terminal phase that we see at end of life without VAD. The deaths we have witnessed here have been very peaceful, gentle, graceful, and honouring of the personhood of the individual, their beliefs, and their values. And afterwards, the families and carers we supported reflect that their loved one was able to be in control of their life right up until the end. And whilst grieving, they express gratitude and relief for the end of their loved one's suffering made possible by their right to choose VAD. So the main priorities for moving forward from a regional perspective were, I had some conversations with just about everybody involved here to ask for everyone's feedback. And it has been recognised that there's a need for more training or education on how to respond to a first request for general medical practitioners, and also more support for regional medical practitioners to be assisted to do the WA VAD training. We've noticed that VAD and first requests over the past 6 months have become more familiar with practice to local teams working in palliative care, but it would be useful to support all medical practitioners with how to respond to a desire to die statement and to a clear and unambiguous request for VAD, and how a first request is submitted. As we saw, half of our patients' first requests were made to doctors who did not know what to do with it. So that's why we thought that was important. And also considering the impact of requiring VAD trained practitioners to travel to regional areas, we wondered, could an incentive be provided to local regional GPs to be able to complete the VAD approved training and build a more accessible team locally in regional areas? The second point that I would just share was a learning, and I touched on it before, but I'd like to encourage all participating regional services to create local and site-centric VAD program managers in their settings, which helps to educate and support teams in the coordination and of the assessment and request processes and provide support for all involved. So we've received constant support from the WA VAD Statewide Care Navigator service when we've needed it, and our patients have also been supported via telehealth. But we identified early that we needed to have our own operational guidelines to help with extra coordination and preparation of the family and carer and the patient to enable someone living in remoter regions to be able to go home to access VAD from hospice. And the third point is regarding the statewide pharmacy service. So living in a regional setting, the process of ensuring delivery of the voluntary assisted dying substance scripts to the statewide pharmacy service from regional areas is dependent on reliable courier mail and airlines if it's not transported to the region by the administering practitioner who's coming from Perth. Unfortunately, in one of our cases, this resulted in delays in being able to administer the VAD substance, and one of our patients deteriorated quickly and died before the substance was dispensed. It was perceived, her death was perceived by her family as a natural end for her, and she did not suffer, but has led some of our team to ask, could a regional hub be considered to produce the authorised substance to expedite delivery in regional areas? So thanks very much to the Voluntary Assisted Dying Board, to Alice and her team at the Statewide Care Navigator Service for their enduring support in these first 6 months. And I'd just like to end by acknowledging all the hard work that Albany Community Hospice, Board of Management, Medical Advisory Committee and all of my team have put into making VAD a safe and available end-of-life option for our patients. And we continue to provide care with kindness, understanding and skill. Thank you.
Thank you so much, Fiona. We really appreciate the methodical approach that you've given to implementing this at Albany Community Hospice and the way that you have involved your team and your community. And I think there are some really great learnings from your experience there, and thank you so much for sharing them with us. We're going to move now to the Q&A panel. Our panel will be Fiona, Simon, Angela and Gareth. And is so often the way, a number of the questions that had been sent through before the session have actually been answered in your presentations, which is great. So there's a couple that we'll focus on there, and then I'm hoping that we'll be able to get through a couple of the questions that have been posed during the event. Even some of those I think have been answered since they were asked, which is exactly what we would hope would happen. So this is a question for anybody who'd like to jump in. Has voluntary assisted dying been accessed by Aboriginal or culturally linguistically diverse patients? And what's been your experience of providing voluntary assisted dying in these cases? We might just take one answer from a panel member if that's possible, so that we can get to as many questions as we can.
Yes, I've had Aboriginal and non-English speaking patients who've accessed and completed the process and died by voluntary assisted dying, and it's complicated sometimes. So particularly when you try and do a video conference assessment of a patient with an interpreter, it just makes the whole thing really complicated. But it can be done, and I think I would have expected that it would have been a bit complicated, but it's all about the approach you bring to it, which is it's patient-centered. You have patients supported by wonderful families and good people around them, and both of those two patients have died well. So it's complicated, but it can be done.
My understanding was unexpectedly the very first patient to access the VAD substance was actually an Aboriginal woman. And during the consultation, we didn't expect to see Aboriginal people making the request very early on. But that's not been the experience, and it's very much an individual choice. And it's really wonderful to see the support that's around people who choose to go down this pathway. I haven't personally been involved with a person who's culturally different, but I did have the privilege of talking to the translator group about VAD and its implementation. And I think I agree with Gareth. It is harder to do, requires more time and consideration, but it's always been part of our plan that would make it available.
Thank you. And there's been a few questions that have come in about bereavement support for families, but also support for staff. So again, I might just throw it open to the panel if there are particular views that you want to share about what you've seen work particularly well in that context.
I think we're still figuring that out. I have two aspects to this. I mean, a lot of our training before this is about the logistics of getting through the process. And what has fortunately been the case is that practitioners who are involved in this are experienced practitioners who have experience of bereavement before this. So you have to be 10 years postgraduate or specialist for more than a year, and hospitals are experienced with bereavement. And I think we've all tried to find our best way forward using the skills that we already have. So we, I think we all have developed our own unique processes and have developed fairly similar processes in terms of how we follow up the family after a VAD death, because the process is often all about the patient until the patient has died, and then there's this rapid transition to it's all about nurturing that family and making sure that they feel supported. And I think we've all figured out our own ways of doing that, and there are more structured ways that we're discussing to try and have a more formalised universal process.
Thank you. I think it's certainly an area that we've identified as needing some continued focus to support families and staff.
We were led by patients in how they wanted this to occur, and it's interesting, we're now I'm certainly feeling that I'm being led by the families of deceased patients in terms of what they want, because and there's similarities and differences amongst all of them about what they want in terms of their bereavement support.
Absolutely. It's always going to be an individual preference.
Also, I think there's some substantial differences depending on where the VAD event occurs. One of the great things about the hospital-based programs is that through our program leads, we integrate all those other aspects of the care of the patient at the end of life, and we take advantage of the bereavement support that exists in the hospital setting. And the program managers are very much linked into the pastoral care teams, very focused around nursing support in ward areas. And so that's a very different model to what if you're in somebody's home with just you and the family. I think this is it's a very important conversation that's relevant in my end of life care lead role, that we've put the kind of grief and bereavement thing on the back burner a little bit. Well, I think we need to bring it forward. But I think Gareth's point is we are being shown the way by the people involved, because we've opened up the conversation. We're happy to explore the whole elements of what the experience is when the patient dies. And I think we're learning a lot more about grief and bereavement. Certainly, compared to my 30-year experience in ICU, I think we're doing a hell of a lot better.
Thank you. That's really good to hear. I'm really pleased to say, Fiona, I can see your hand up. I'm just going to flag as well that Claire Fellingham is online. So Claire, we have viewed your video. Thank you so much. And we have now moved to questions. And if it's okay with you, we'll come to you with a question about conscientious objection in a moment. Fiona, I'll go to you first.
I just wanted to speak to that last issue around grief and bereavement. Here our patients are admitted, as I said, time to from request to end of life for 2 to 3 weeks, and in that time 24 hours a day they're being cared for by the teams here at Hospice. And so there are relationships that our team build with the patient and their family, that in that time we get to understand what those bereavement care needs will be. And we have actually really witnessed the grieving process amplify from the moment of first request for the carer, whereas there's relief for the patient. We start to see the bereavement start earlier, before death, and this is it does require a lot more resources. We are really responding to it well, and we do reach out to the family and carer remaining after the death and allow them to let us know if they need more support from us or not.
Thanks so much. Claire, are you online and able to talk about how you have been able to safely accommodate staff preferences within your hospital around conscientious objection? Hi, Claire.
Hi there. Can you see me?
Great
Can you
to
hear
see
me?
you. Yes.
Oh,
Hello,
fantastic.
Claire.
Hello, everybody. Question would you like me to answer? Sorry.
One of the questions that has come in, Claire, is how easily have hospitals been able to integrate voluntary assisted dying as an additional end-of-life choice for patients? Has conscientious objection among staff been safely accommodated?
Well, I would like to answer that one by saying I very, very much hope that we have, certainly we've striven from the very, very beginning to accommodate every single person's point of view from one end of the spectrum to the other regarding voluntary assisted dying, of course acknowledging that it's a very, very polarising subject, and it's a subject that a lot of people have struggled with and grappled with entering into everyday medical practice. So I think the best way to answer that question is to go right back to the beginning and say that as clinical lead, I made sure that in every piece of education or awareness that I devised from the very beginning, that there was the certainty and the vocalisation that all points of view would be respected and that nobody would be forced or coerced into taking part in any part of voluntary assisted dying if they weren't comfortable to do so. That being said, I think by having a sort of very open and honest campaign of awareness and really just not being afraid to discuss voluntary assisted dying and to create forums for other people, for all staff members to voice their views. We had one-on-one sessions, ward-based sessions, we ran wellbeing sessions, we ran confidential drop-in sessions where people could ask questions that were anonymised. We ran a staff survey to look at our staff views. We really just did try to, from the beginning, acknowledge and accommodate everybody's views. And then once the 1st of July rolled around and it became a reality that people were accessing this within the hospitals in our hospital network, again, we just continued with those programs of staff education and awareness, inviting staff to air their views, and ensuring that when a patient had made a request for voluntary assisted dying, we had a cohort of trained professionals, both the practitioners and our wonderful program manager who helps to run the service across all of our hospital sites, and made sure that everybody knew that they had somebody to contact and that the organisation and the discussion and the support of the patient accessing voluntary assisted dying occurred by those specialist groups of people, and there weren't sort of people who didn't want to have anything to do with it left trying to deal with it for the patient.
Thanks so much, Claire. It's a really great example of how you've implemented that at East Metro. Thank you. I'm aware that we are overdue to go to a break. I'm going to suggest that we take one more question in the panel now, and then we'll go to a 10-minute break. So I'll invite all panel members to leap in if you'd like to answer this one, but we probably will keep it to just one or two responses if that's okay. The question is, have any panel members had experience with patients who are assessed as ineligible for voluntary assisted dying, and how did those conversations play out?
If I can speak first,
thank you.
Briefly. The only people that I have found ineligible were because of loss of capacity due to advancing illness. And so the conversations had there were with family who were often quite distressed initially, but then they saw that their family member was actually not the person that they knew anymore, and they were obviously beyond making those decisions. So it's a sad thing, but it's kind of, it was acceptable to the family. Would anyone like to speak to having not found someone not eligible right from the beginning?
I think that discussion, I've not had anybody with no life-limiting illness who has come for a first assessment. So there's not been anybody where I've said you do not meet the eligibility criteria in any way, shape or form. But there have been people where the eligibility has been questionable, and it's been a matter of repeated assessments and time for the natural history of the disease that they're dying from to be declared. So I think there's a lot of, and I know this has been the situation over East as well, there have been discussions of you're not eligible right now, but it's not never. We'll keep the discussion going and see what happens with time.
So like so many end of life discussions is often an ongoing conversation.
And even with the patients who died ultimately not by VAD, having potentially got to the point of a prescription, but losing capacity, I think most families that I've been involved in that situation have been able to reflect that the person still died, was heard, is the most important thing, and that they still died comfortably and peacefully and with as much dignity as the situation allowed.
Thank you so much. Thank you to everybody on the panel for your presentations, and welcome back everybody for the final session of the forum today. This final session will present lived experiences of voluntary assisted dying from family members who've accessed people who have accessed voluntary assisted dying. And can I just start by expressing our very sincere gratitude to all the people who have shared their stories for today's session. It is early in the implementation of voluntary assisted dying, and when we started to organise this forum, we weren't sure if there would be family members who would be ready and able yet to talk about their experience, because it is a very fresh and new experience. And we are so grateful that a number of people have shared their stories so that our colleagues here at the table with me can read those stories for you today. And also that one of our family members has been willing to record a video that we will show to you in a moment. So wanted to express our very sincere thanks to all of those people for their bravery and their honesty in sharing their stories with us. I'll go first to Alice, who's going to read the story of one of their family members.
Beautiful. So mine is actually from a lady herself from reasonably early on after voluntary assisted dying was legalised. So she was a wonderful lady in her early 70s with motor neurone disease, and sadly, like many of other patients that we have supported with MND, wasn't able to talk anymore. So we had organised to meet via email. And when I arrived at her house and we're comfortably sitting on her couch, she handed me this piece of paper because she had really wanted to ensure I understood exactly why she had reached out to us and what this meant for her to have this choice available to her. So she called this her statement for request for access to voluntary assisted dying. I would like to be accepted to voluntary assisted dying. 7 months ago, I was working a full-time job, which was stressful but rewarding. I decided to leave in January because I wasn't feeling on top form. 4 months after this, I received the diagnosis from my neurologist that I had motor neurone disease. My world was shattered. I have always been an independent person. I looked after myself and tried to stay fit and healthy. I went to the gym 3 times a week, played golf, did a regular 8-kilometre walk because I've always enjoyed sport. Prior to this diagnosis, I was about to move interstate to be with my brother and family and closer to my daughter. My diagnosis put an end to this. I was advised by my neurologist that this wouldn't be a good idea, as I was going to a small town where I wouldn't have access to the same level of support that I have here in Western Australia. My MND started with my speech, and now I'm unable to speak at all. I've gone from being a very social person to someone who doesn't want to go out anymore. I was advised to have a peg fitted because eating, swallowing and drinking had become more difficult. I was told I had to stop driving because I had a weakness down the right side of my body. and I was getting worse, and I was having trouble now using my right hand. I don't want to be here anymore because I don't have a life as far as I'm concerned. My friends are very supportive and I have access to all the support groups, but I don't want to be in a wheelchair in a care home with tubes down my throat. I want this to end as soon as possible. Please help me to achieve this. My will has been done. I've paid for my funeral and I've given written instructions to a friend who has power of attorney for the people and companies that need to be notified. I am ready. I have always been a supporter of voluntary assisted dying, and I'm fortunate enough to live in a state that has legalised it. Thank you. And as she sat with me, why I read this and held my hand, she's a very remarkable woman, this one. And at the end, she was still able to write a little bit. So she painstakingly and very carefully wrote down for me, I love life, but this is not my life. And she died in her own home, supported by a practitioner and very gently held by her best friend's son, cradled. In fact, it was one of the most beautiful things I've ever seen, with her best friends there with her, with music playing, more than 1 million scented candles, and some really special music on, all of them there together, and so incredibly with her and supporting her in her journey and her choice.
Thank you so much, Alice. Welcome Kim Grieve now, who's one of the fabulous members of the Care Navigator team, to share another story with us.
So I have the honour to read out the reflections of a wife, a gentleman who contacted our service really early on last year. I had the pleasure and honour of meeting him in their home and having ongoing support and contact and able to help navigate their way through the VAD process, supporting both themselves and the practitioners involved. It's just 6 months since my husband took advantage of this program to end his life in a peaceful and dignified manner. He was diagnosed in March 21 with MMD and passed away in August 21. MMD, as you are aware, this is a terminal disease with little or no relief from drugs or treatments. He was a pharmacist and very aware of what this diagnosis meant for him, and was determined to take advantage of the VAD to end his life when the quality of his life made the final decision for him. There are various options regarding this program, be it personal or religious, but I can truly say that if you have someone with a terminal illness, you must know that this program is a blessing. The process leading up to this was made with great kindness, sympathy and professionalism by all concerned in preparation for his final day. As you will be aware, 3 doctors are required to complete the process. You can source this personally, or you can, or with the help of the VAD coordinator, which is what we did, and their help took much of the stress out of the process. Once the doctors have completed their interviews and all the paperwork is in place, the next step, the decision to go ahead, is made by the patient, his or herself, only with no pressure from anyone else. On the final day, the administrating doctor prepares the patient privately. The only evidence is a cannula covered by dressing to hold it in place. The family then can say their goodbyes. The doctor tells the patient that she or he will administer medication and that he will go to sleep and not wake up. If that is their wish, the dose is administered and he slowly goes off peacefully to his final sleep.
Thanks so much, Kim. Gareth, thank you for sharing, I think, a story and a letter.
Indeed, yeah, double. So my first is the reflections of the wife of a patient of mine who died 10 weeks ago. My name is Lisa. At the time of my husband Stephen's VAD date, we had been together for 35 years. Yes, we married young. Here is my reflection of our VAD journey. 2 days after Stephen celebrated his 53rd birthday in August of 2021, he experienced rapid and progressive symptoms of a bowel obstruction, which was to be diagnosed as stage 4 pancreatic cancer. 8 weeks from his initial symptoms of severe reflux with abdominal pain, he was a Royal Flying Doctor flight from the mine site we both worked at to the closest regional hospital. 27 days of hospitalisation in 5 hospitals, numerous IV hydration bags, cannulas, PICC lines, 1 very painful attempt at a PICC line, 18 days of being nil by mouth, 5 days with a TPN bag, 5 CT scans, 1 MRI, 2 endoscopic procedures, 1 endoscopic ultrasound, insertion of an upper GI stent, a PET scan, and 4 chemotherapy treatments with pegfilgrastim injections, weight loss of 12 kilos, and he started losing his hair. This was our insight into what could also happen at the end of life. Stephen didn't want to die. We had that discussion after being advised he possibly only had 3 months to live unless he took palliative chemotherapy. Our journey of 1,000 medical things you never wanted to know started. Soon after, a documentary was aired on TV. You may have watched it, Laura's Choice. It was clear that this was a choice Stephen wanted also. If his cancer took away his quality of life with the outcome being death, he wanted the choice also. Stephen continued the chemo treatments, completing 9 rounds of gemcitabine and paclitaxel, which had devastating side effects, including neuropathy. The indignity of losing sensation in his fingers to the point he could not fasten or unfasten buttons on clothing, amongst other side effects, was hard on a very independent man. Nor being able to enjoy his hobby of painting, he was unable to hold a brush. The disease was taking away his quality of life. We both tracked the progress of legislation in WA to pass VAD. During this time, we changed oncologists, had a break from gemcitabine and paclitaxel, and started FOLFIRINOX. But after 3 treatments, we were advised that the cancer did not respond to the FOLFIRINOX. The tumour markers were rising rapidly, and so we knew we had to put our ducks in a row. Chemo finished, and we let the family know that Stephen possibly only had maybe 3 months minimum once again. There was no other chemo choices left. It was July 2021. That same month, VAD had become accessible to West Australians, and we made the call to the VAD Care Navigator service. We both knew we may not have enough time, but we started putting those ducks in a row in case the disease progressed to the point he may have been incapacitated. It was very helpful to have our consults with the coordinating practitioner at home, as sometimes Stephen was housebound with his reactions to chemo, and also being able to use a webcam for the consulting practitioner was a blessing. I am sure there are others who are in the final stages of their life and are often housebound, so this service is helpful. Western Australia has a way to go with VAD. It's only been 7 months since it's been accessible as I write this reflection. Oncologists and family GPs may not be on board with VAD for various and very legal reasons, as too some friends and family have conflicting opinions. Also, the general community are ill-advised, such as viewing it as suicide. Suicide is a choice between life and death, but VAD is a choice between 2 deaths that are inevitable. So it would have been difficult to seek assistance and guidance without the VAD Care Navigator service. At this point in time, we had not discussed that with the family, although we did suggest there was this awesome but confronting documentary called Laura's Choice you might like to watch. We're able to put in place end-of-life care planning alongside advanced care directives, legal wills and medical treatment decisions. But there is this negative response to accessing the legal right to choose the time and mode of our death, such as VAD. Let's hope that this will eventually be accepted as the norm. We enjoyed the honeymoon stage when you cease chemotherapy treatment and you feel normal, and we were able to complete all the steps and requirements with time before the disease returned. Stephen wanted control of his pain and suffering, a choice to end his life with dignity still intact, not to be on terminal sedation in a hospital bed with all sorts of tubes and bags attached, and away from the comfort of his home, pottering around in the garden and with family nearby. VAD allowed Stephen a safe and compassionate end of life with family around him. It was voluntary. Stephen knew he was going to die. His initial symptoms had returned, which we thought would happen, and knowing what had happened to him from the outset of the disease, he did not want to deteriorate and incur invasive treatments like before. Stephen was able to choose his VAD date at a time when his quality of life had deteriorated, to a point he didn't want any further progression or participation with the cancer that was taking over his body. His death was not traumatic. Our family had time to reflect on his choice after discussing his decision a few weeks earlier. So when Stephen decided it was time, the family gathered a few days before and discussed his impending VAD date, and then returned on that day to spend Stephen's last hours chatting and saying final goodbyes in the comfort of his own home. I personally cannot recall anyone saying to me that they hugged and thanked their doctor when a loved one passed, nor the deceased doing the same before they died. His hand was held by someone he loved, and he was not alone. What a beautiful way to leave your life. Cancer had already robbed Stephen of his quality of life. It was the death he was comfortable with, voluntary, and on his terms.
Thank you, Gareth. And thank you, Kim and Alice, for reading those really stories. I'm going to move now to a video which has been recorded by Chris, who's the partner of one of the patients who accessed voluntary assisted dying. Thank you, Chris.
Hi, my name's and this is Trish, my partner of 21 years. Trish elected to have VAD on the 16th of November last year. Trish was diagnosed with ovarian cancer in September last year after several months being legal. The process for us was really quite easy. We'd spent 5 weeks at Albany Hospice, who were marvellous. They were very supportive of the decisions that Trish made and that I made. They enabled us to have meetings and talk with people from the VAD team in a safe environment. Trish was really, really sick and had opted not to have any treatment because obviously ovarian cancer is terminal. So she knew that no matter what happened, she wasn't going to survive. And the only real joy for her was the fact that she was able to decide. We spent a week with her foster children. She has 3 adult foster children and a 12-year-old grandchild. And Trish got to say goodbye, they got to say goodbye, we got to cry together, discuss the process, discuss what was happening to her. She also got to have that discussion with friends and dear family members. The process started with a telehealth conference or meeting with the lovely Gareth. Then Gareth came to Albany to meet Trish face to face. We both fell madly in love with him. He's a gentle, lovely, lovely young man. Trish wanted to adopt him, but we didn't think his family would agree. Gareth explained the process to us in detail, answered questions from Trish, from me, and Trish's best friend of 53 years, Yvonne. We felt supported by Gareth and the team and the Albany Hospice. We felt as though we were being held very gently by all of those people through this process. Gareth explained the process to Trish. They decided on a day, which was the 16th of November. Gareth was very gentle. He came in and said to Trish, I can come back 5 minutes, 5 weeks, or never. And Trish's words to him were, let's get the show on the road, which is what we did. He was very respectful of our time, and after explained to us how the injections would be administered, I lay next to Trish and held her in my arms, as was her wish, and she passed very peacefully in my arms. Well, I'll be forever grateful that she was given the dignity of choosing the time and manner of her death after she lost everything to ovarian cancer. Her body wasn't working. She was fearful of her mental state. She was taking drugs. And this is a woman that wouldn't take Panadol for a toothache. So her quality of life had really declined, and she was very grateful. And I'm very grateful, particularly to Gareth. So that's our story. Thank you. Nikki is for you, Gareth. That's how she looks when she's well.
Thank you so much, Chris. And thank you also to Lisa, who I know are online watching today. We are so grateful to you for being willing to share your stories. It's a brave and really generous thing to do, and we're very grateful to you for that. And for all of us in the room here and online, listening to these stories is incredibly rewarding, but also hard. And I would encourage all of you to reach out to people around you for support if this has been hard and distressing for you to hear, and also to know that there are professional services available who can provide you with some support if you need it, either in relation to what you've heard today or generally in terms of working on this very important but sometimes also very difficult area. I know that we were also going to read a letter to the editor. Gareth, are you willing to do that as we then invite Simon to join us for the final closing comments? Thanks, Gareth.
Yeah. I had the privilege of looking after Colin, who was a man who between the 1980s and 1990s, every day of the week would have a letter to the editor published in either the West Australian or the Australian, and often both. And this is his final letter to the editor, in reply to a letter from a Queensland anaesthetist who was saying that clinicians wouldn't want to be involved in voluntary assisted dying. Dr. John Murray really needs to get out a bit more to update himself on how many doctors feel about voluntary assisted dying. I have a terminal illness that will kill me within 6 months, so I qualify for relief under VAD laws in Western Australia, where we need to see 2 doctors who have undergone specialist training for VAD qualification. And the 2 men who've taken up my case are 2 of the finest humans I've had the privilege to meet since arriving on this planet in 1947. Not only have they been superbly professional in their dealings with me, they do it for the sheer joy of being able to help people like me who want to dictate when to depart without subjecting their families to witness a steady decline, a prospect that horrifies my children. He was one of the most pragmatic men I've ever met in my life, and Colin died very peacefully a couple of weeks ago with his family by his side exactly as he wanted.
Thank you so much, Gareth, and thank you to Colin too for sharing his story with us. I'll invite Simon Towler now to close the forum. Thank you, Simon.
So, particularly the 161 people who are still out there, you are my heroes. You've stayed with us for the whole morning. I think it would be obvious to reflect that to have the patient and family stories at the end of today has been in many ways the most poignant part of the whole meeting and reminds us exactly what we're here for and why we put on this for today. It was marvellous to hear those stories, and I think to be watching from behind as some of my colleagues were smiling smirkily as they were telling the stories, that very personal element of what we've heard today was evident. Today we've given you the opportunity to hear from all the players in the VAD services and the way it's been implemented in WA. I hope you've been encouraged and are confident you can see the VAD in WA has been implemented safely and respectfully, but remains under significant vigilance and care, and it is appropriate for what we're trying to provide. It is reassuring to know that the VAD board has been responsive to the issues that have been raised by providers. We are grateful, but I remind you there is no process in healthcare, none at all, that comes under the degree of scrutiny which voluntary assisted dying does appropriately under the legislation. We've heard today there are significant ongoing challenges. It's disappointing that remuneration keeps coming up. We've heard the message, and we will continue to advocate for providers to be remunerated appropriately for the work they do. We've noted that in New Zealand, where voluntary assisted dying is being implemented, the New Zealand government has developed what seems like a reasonable and full payment schedule. And we will continue to raise that as an important issue. The need for more medical practitioners to become VAD providers has also been cleared. We are fortunately considering and looking to support training, and through this, we will continue to support and assist and nurture in the community practice clinicians who choose to come along this pathway. It's important to acknowledge the stories. The patient and the family stories are the message of the success of the implementation to date in WA. It is a privilege to hear them, and their stories validate the passion and commitment which Gareth emphasised in the history of how VAD came to be enacted in Parliament in 2019. It's been interesting to note that although the beginnings of VAD in Victoria had some substantial challenges in the public arena with people gathering outside Peter McCallum and concerned, in WA the introduction was more gentle. I hope that you have found this forum of value. We look forward to getting your feedback. This is the first time we've had an open forum on this issue. There have been many meetings of the community practice, but so much about voluntary assisted dying has to be held somewhat in secret. We're really pleased today to have been able to offer this opportunity for you to encounter and be encouraged by the lessons that we can do this safely and well. I wish to also particularly acknowledge the people sitting around me in this room. A forum like this doesn't happen magically. A huge amount of work has been put together today to ensure that the forum has been made available. We have over 300 people who registered for the forum today. I'm really pleased for those of you who are still here and listening right at the end of what has been quite a long morning. I wish we could have been together. This is a very personal issue. It is a very personal experience. But it is important that we held the forum. The time is right to do it. I wish you all a great day. We look forward to hearing back from you, and we are available here to support you if you need us. Thank you very much for your attention.
Thank you so much, Simon. Really appreciate your summary and your leadership in this area. It's very gratefully received. And everybody, we are now at the end of the forum. I'd like to just reiterate our thanks to all the speakers for their time today and for sharing their experiences about voluntary assisted dying from the first 6 months in WA. And to thank all of you online for joining us. As Simon says, in a different situation, we would have all been together in the lecture theatre at Fiona Stanley, but we're delighted that we were able to proceed with the forum today to give you this really important update and information. And again, I would just add my thanks to the team in the End of Life Care program and also in the VAD Board Secretariat for all of their work in preparing for the forum today and supporting it. So thank you again. I hope the rest of your day is great, and thanks very much for taking the time to join us this morning. Thanks, everybody.